Welcome to Mad Medicine with Miss P. Good to see y'all again. We're going to continue on with assessment today, picking up with range of motion. I'm going to try like crazy to keep this in one video, but y'all, range of motion, you have to describe it. You have to be specific. And yes, it could be a lot, but you need to make sure that what you're writing down matches the patient in bed, like I always say, right? So you have one of basically 5 choices. You can describe the range of motion as active range of motion, passive range of motion, which is performed by you, not the patient. That's why it's passive. Full range of motion, moves all extremities or moves all extremities well, depending on what your, and don't use those acronyms unless you know what your facility allows. So those are basically, for the most part, there's a couple of variations, but for the most part, that's what you want to describe. So full range of motion means that you noticed upon your assessment that this patient has full range of motion of all of their joints. It doesn't necessarily mean that you caught them doing this or, with their hips and that sort of thing, but you walk into your patient's room, it's a 36-year-old female that is there because she flipped her four-wheeler in the creek and has cellulitis, and she's up and moving around and doing her normal stuff and taking care of herself. She should have full range of motion. That means she doesn't have a frozen shoulder or some sort of joint defect. And if you've noticed that throughout your assessment, which should only take maybe 15, 20 minutes at most, chances are that patient has full range of motion. When you get into a little bit older patient's room, I always say this, like if they kind of move like this, or you need help sitting them up to listen to their lungs and that sort of thing, you're not going to be able to use the full range of motion. If they reach out, put their cup off to the side, push the table out of the way and sit straight up and kind of assist you and help you move, they probably have full range of motion, and you might go into a little detail and say like, hey, can you move that, arms for me? Or can you reach this? Or you might even say, touch my hands and, hold them up, that sort of thing. That's full range of motion. And sometimes you can even chart full range of motion for an 86-year-old male. You wouldn't chart it like that word for word, but that lets you know that this, 86-year-old patient or 92-year-old patient has full range of motion, meaning there's no contractures, there's no frozen joints or shoulders or anything like that. And while they're not going to be able to do a straddle or split anytime soon, their hip joints move well enough to get them up and moving into the bathroom, or while they're in bed, if you're cleaning them up, they can, assist you and do some abduction and adduction to where you can see that those hip joints move correctly. That's full range of motion. For those of you that keep charting active range of motion, remember that means they actively participated in it. 26 years of nursing, I have never charted active range of motion. God bless those have time to do that. That means you stood at the foot of the bed and said, okay, do this for me and do this for me, and then move your elbow and move your wrist and move your fingers and your hands and your hips, knees, and ankles, and you did, some dorsiflexion, and you made sure that all of their joints are moving actively while you sit there and watch it. That's active range of motion. So that is something that you made them perform. And for those of you that do, fabulous. There's nothing wrong with that. You should. We all should. I've just never had time for that. If you have to do it, then it is passive range of motion. So in passive range of motion, you performed it while they kind of fought you or tried to assist you or were flaccid, right? So I might say something like passive range of motion performed with flaccidity. Passive range of motion performed to right-sided extremities with resistance and left-sided extremities with flaccidity, right? So that lets you know that maybe they had a stroke and they're kind of flaccid on one side and they're a little stiff and, can only do so much on the other side. And when you have to go limb to limb, it's a pain in the butt, but you have to go limb to limb. So if they can move this one arm, but they can only do so much with this, then you have to go degrees. So can they 90 degrees abduct on this side? If it's completely contractured, then you need that degree as well. So if it's a 30-degree contracture because they can't move anything past that, that's 30 degrees, like a protractor, in contraction. And then you have to say so per joint. And I know it can be a lot. If they're contractured in fists and you try to open it up and you can't, that is a contracture, with complete flexion, or you can say, you can use the term fist. If you can open it up, they can't do it, but you can open it up, that's not a contracture. That's kind of how they hold their hand. So you know that they need a lot of passive range of motion before they develop contractures. That shouldn't be happening, right? Especially in skilled facilities with 24-hour nursing care. We shouldn't be developing contractures. Some, to an extent, may be impossible to avoid, but on average, we shouldn't be developing contractures with 24-hour nursing care. PT, OT, and tech support and that sort of thing, we should be able to get these joints moving on a regular basis to where those contractures don't set up. So if you've got a patient that can move all their extremities, considering they're 112, then you might say move all extremities or move all extremities well. So for that, 92-year-old lady who gets up in her walker and she kind of, walks down the hall, but she's a little hunched over and she kind of keeps her movement still. That's still moving all extremities, but she doesn't necessarily have full range of motion. So make sure you differentiate between the two. And some patients, one day you thought it was this, and then the next day suddenly they can do that. And that's okay. That's going to change. But whatever you chart has to match that patient in bed. You have to be very specific in what can and can't move. So if that patient has full range of motion, then you just leave it alone. Like for me, what you chart is capital F, capital R, capital O, capital M from, right? Because all acronyms have to have capital letters. That's what lets you know each letter stands for a word. When you don't capitalize that and you write like capital F, lowercase ROM, that's the word from. So make sure you recognize anytime that you are writing an acronym or you see an acronym, that means each letter stands for something versus an abbreviation. Okay, it's not the same thing. When you abbreviate something like ABD for abdomen, it's not capital A, capital B, capital D, because each letter doesn't stand for something. It's an abbreviation of abdomen. So when we talk about range of motion, you can use capital FROM, or with passive range of motion, like I said, you would say capital PROM, right? All capitals. And for me, I know not all instructors say this, but I want to be able to be on the stand. If I chart something and they're like, Nurse Padalano, are you saying that she wasn't able to move her left arm? Say, well, what do my notes read? If you're capable of reading, you'd be able to read it right there. And what's it say? Passive range of motion performed to all extremities with left-sided flaccidity. Or passive range of motion performed to right-sided extremities with resistance, which means they were kind of fighting me a little bit, or with stiffness, they wanted to move but couldn't, or even assistance. They were trying to assist me but didn't have the strength to continue on completely flexing or extension, right? So be specific. So anything I write, it should be pretty crystal clear that if they've got questions, it's because they don't understand the words I used, or they haven't consulted a nurse that understands the words I use. But I should be able to read that years from now, months from now, decades from now, and say, yes, okay, I remember this lady to an extent. Let's hope if my charting is that good, I might be able to jog it and say, right, so she had her left arm contractured in flexion at her elbow about 30 degrees. Her abduction at that left shoulder was about 90. She couldn't really go past that. And she kind of held her hand in a fist, but it wasn't actually contractured. I could straighten it out, but she couldn't straighten it out. So she was flaccid in all other extremities except, that description. And that's exactly how I would chart it. Passive range of motion performed to right-sided extremities and left lower extremity with the contractures I described to the left upper extremity or left arm, you can be specific. So all of that should be so easily understood and explained that there shouldn't be questions. So when you guys write, full range of motion, I'm like, really? Because it said in the history that she had a CVA with left-sided weakness. So if they had full range of motion, that's fine. And we can talk about grips and pedals and their strength later. But if I go in there and, she can move this arm just fine, and then she can like kind of move this arm a little bit, but doesn't really have the strength or the tone or the, like the fine motor skills or even large motor skills to really move that shoulder, then that's not full range of motion without describing which arms or which limbs do and don't have further motion. So as you're charting this, be specific that you're not leaving anything out. And if you have a contracture, not a contraction, that's in grammar in English, but a contracture, you have to be specific in how you're describing how the degree or the angle that contracture is expressed. So make sure all of that is as clear as possible. You want to be able to not have anything questioned, anybody reading your notes, or PT comes in and says, hey, am I going to be able to get this patient out of bed? What do you think? I should be able to read some notes and have an idea. And I've had that happen to me before. I've had a doctor and a PT at the hospital where I was working come in and say, hey, how's she getting out of bed? And I was like, well, I just got here and I only got so much report, but let me look it up. And as I'm looking it up, there was nothing in there that said anything about range of motion or activity or her ability at all. It was really, really lacking. So I was like, I have no idea. You can go in and see what you got. Get her up and, take 5 people with you to make sure she doesn't fall because there was nothing charted. I would like someone to be able to read my notes and be like, okay, I know exactly what I got here. I know exactly what to expect. Pretty simple, pretty easy, not too confusing, and let it be as detailed as possible without writing a book. I don't want you guys writing a book. Anytime I get an assessment and I have to flip it over, I flip the entire normal, 8 by 10 notebook piece of paper flipped over, and I'm like, unless something happened and you have additional notes to write, it should be a paragraph like about this big. Okay, and if you write large and you got your jumbo crayon out, it should be maybe a paragraph about this big. Anything that I have to flip over, you might be doing it wrong. You're writing way too much stuff. Or maybe something happened. Maybe, if you've got other notes to write, that's fine. But just your assessment alone shouldn't have any interventions in it. And it's just an assessment. You're just assessing the patient head to toe, and that's all. Like I always say, if you notice there's a problem, you would stop your assessment, chart that issue, date, time it correctly, complete that note, API, SOAPy, whatever you want to use. Then go back and start your assessment from head to toe as if that's the time you're starting it. Whether you had to separate it or not, whenever you complete it is kind of about the time that you can, chart it or count back to when you started for the most part, not from before the initial issue. So that's range of motion. And for me, it's not that complicated. Just remember that when you perform passive range of motion, you have to chart what you got from that patient. So I want you to chart passive range of motion performed with, and then describe as you were grabbing that arm and moving it. Was it resistance? Was it stiffness? Was it rigidity? Was it flaccidity? Was it, with some assistance? They could assist you to where they weren't paralyzed, but they didn't have the strength enough to complete that motion. So that's probably, passive range of motion is probably the toughest thing that I'm trying to get you, y'all to chart correctly. With full range of motion, they either have it or they don't. And usually by the time you go in there, introduce yourself, get some vitals, and then begin your assessment, it's been maybe an hour or so. You should be able to know at that point whether they have full range of motion or not. Or you can even ask them, if they're awake, alert, and oriented, you can say, you have any problems with your hips or shoulders, your elbows, knees, joints, hips, anything, can you move everything just fine? And, they'll say like, oh yeah, just for sure. Or more often than not, they're like, well, I hurt this hip a while ago and it doesn't really do this. So to evaluate that hip a little bit more in detail before just throwing out, full range of motion and assuming that all their joints move correctly. So moves all extremities means that, for a little old lady, she may not be able to reach out, to grab something, but you saw her kind of, reach to get something, or she went to do this, or she kind of moved, or she can maybe get up and go to the bathroom, but as she's, moving, you may be like, oh, let me help you, or you kind of look a little wobbly. So that's moves all extremities. Moves all extremities well, like I said, is in full range of motion, but she can move and work those extremities and she's using them well, or at all. When they're in bed and it's hard to determine, I might say like, hey, can you touch my hand up here? Or can you reach out here? Can you grab my finger? And not pull my finger. And I may have them do those things to see if they can move those joints as well as they think they can, or those limbs as well as they think they can. So I try to be as specific as possible with range of motion. And after range of motion, I kind of go straight into grips and pedals, because as you're evaluating their limbs and what they can and can't move, I also have them, I say, I'll put my fingers out like this. I say, give me a good squeeze. And grips are not strong bilaterally. They're strong and equal. So you can squeeze over here and say, yeah, those were both pretty strong. And then when you squeeze together, you're like, wow, the right's a lot stronger than the left. That's when you have to be specific that they're not equal. So when we talk about grips and pedals, they want to be strong and equal, weak and equal, strong on right, weak on left, strong right greater than left, right? So if they're stronger on the right, you can use the greater than sign versus the left, or they're weak greater than on the left versus the right. So if you're going to use that greater than sign, make sure you understand that whatever it's opening to is it is being described with the word you use. So if it's weaker on the left, then that has to be opened up to the left if you're using the word weak. If you're saying they're strong, but the right is stronger than the left. So you would say, they're both pretty weak, but the left is weaker, then that's opened up to the L, right? If you say that they're both pretty strong, but the right is definitely stronger, then you would say grips and pedals strong, right greater than left, right? So, or correct. So make sure you understand that it's not about bilateral. When we chart pulses, that's bilateral, because you're grading that, and you're grading it as saying that's a +3 and that's a +3, so it's +3 bilaterally. When you're talking about grips and pedals, you have to do them at the same time to make sure that they are equal. So grips and pedals should be strong and equal. Or let's say pedals weak and equal, or pedals absent. So grips strong and equal, pedals absent with bilateral foot drop noted, or severe bilateral foot drop noted, or maybe they're flaccid, so pedals absent, and that just kind of lets you know that they can't, do it at all for whatever reason. So just make sure you're being very specific in how you're determining that range of motion. And if you have to go limb by limb, then go limb by limb. And make sure it is complete and you're not leaving anything out. And if you notice a change, then good, maybe things are getting better. If you notice things getting worse, that's an issue and we need to recognize that. So you come in on a Monday and grips and pedals are strong and equal, full range of motion. And let's say you're in a long-term care facility and you've got 3 days off, and then you come back on Thursday and their grips are strong on the right and weak on the left. What just happened? Right. That's why we chart these things. It's to notice a difference, to when you recognize a difference, when you find a problem, you do something about it. We're assessing these patients with that fine-tooth comb, that laser beam from scalp to toenails, to make sure if there's any change in their assessment and any findings that you now notice are different, that you need to do something about and recognize when it's a problem. It's probably the biggest issue I have with students, recognizing that there's a problem. When they chart something like it's totally normal and they'll say like grip strong on left, absent on right. And I'm like, there's nothing in the chart that says that. I already went through the entire history. I've read like almost the entire chart. I know this patient forward and backward. Even if I haven't been in the room yet, I know what they look like. I read the chart, and assuming the charting is correct, we should know what that patient looks like in bed. So when they get that and I'm like, is this new? Did something just happen? What's going on? We need to know what the case is. And y'all just chart it like, everything is totally normal. Or you chart like, the pulses, the pedal pulses are, +2 bilaterally. That means they're easily occluded. That's not okay. And you're not recognizing that as not okay. And if it is okay, then you need to explain, this is why, this is what's happening, this is the situation, this patient just went through this issue, or we have a problem, but it shouldn't be. If you're not getting +3 with your pulses, and we'll talk about that maybe next week or the week after, you need to recognize when it's not okay. And especially with range of motion, when there's a difference in what you found the day before, the week before, or in the charting before. So I try to wrap that all up as quickly as I can, keeping it under this 20-minute mark, because I got a new phone. I just haven't hooked it up yet. So don't give me crap, Emily. I'm working on it. I'm going today, as a matter of fact, and I'm already running late. So that's range of motion in a nutshell for the most part. And then, of course, if you've got a patient that is incapable of following commands, then you might have to say, unable to assess grips and pedals, patient is unable to, squeeze on command or dorsiflex on command. And if you don't use pedals, that's fine. The push and pull thing, I don't know what the hell that is. Please stop writing that. That the positive push and pull, or the feet push and pull, or I have no idea what that is. It's called dorsiflexion. If you don't want to chart pedal, because that's literally how you drive a car, right? You hit the pedals because you're dorsiflexing. You're not moving at your shoulder to hit those pedals. You're dorsiflexing, using that Achilles tendon to hit the brake and hit the gas. Those are pedals. So that dorsiflexion is what we're testing. So you could say positive dorsiflexion, strong and equal, or you can just use pedals, because that movement is called a pedal movement, which is fine. That's why we're bipedalar. We have pedals. That's kind of how it's not pedal, that's a pulse, but pedals, that's that movement. So, describe that the best you can. And I know it can be confusing and not all instructors write the same thing, and that's fine. But when you get out there, as long as you're charting to where you completely understand what you mean by that, and you have no questions, anybody reading that didn't say like, well, what does she mean by that? Or that doesn't make sense, you should be pretty good. It's not my way or the highway. I always say, if it makes sense and anybody reading it says, yeah, that's pretty good, that's on the money, well, then it's good enough. So just make sure that if you were ever being questioned, you wouldn't say, well, what I meant by that is, oh, that's not what I meant to write, or, I should have said this. you kind of got to go over your charting with a fine tooth comb and make sure it's correct. And I've done that. Like I told you before, I'll have another nurse read and say, hey, what do you think about this? Or does that make sense? And I encourage the students, if you've got, some friends in your group and you don't mind them reading your stuff and you're not all worried about being judgmental, remember, most of these people you're not going to see after. I know you're best friends now, but in a couple years from now, you may never see them again. I'm still good friends with maybe 2 people that I went to nursing school with. One I can remember for sure. The second I'm throwing in there because I would like to think that at least, Chris. Yeah, okay. I still kind of talk to Chris from time to time on Facebook. Thank God for Facebook. Other than that, don't worry about what people think. Get some help, and y'all need to work as a team and, try to help each other out. That's really what nursing is about. So that's about it with range of motion. So I'm just going to end this with my little pet peeve. Many that I have. Adverbs. Guys, adverbs. Don't be afraid to use them. Drive carefully. It's not drive careful. It's drive carefully. That's describing how they're going to drive. That's what an adverb is. Oh, that can be easily done. Right? It's not easy done. It's easily done because you're describing how one's going to do something. You're going to get it done easily. Don't be afraid of adverbs. It's a good thing. I promise. Okay, so I'm afraid this is going to shut off. So I'm out. Hugs and kisses. Hope all is going well. And y'all, get somebody to go back and watch these videos that were only watched like 32 times. This is very stressful for me, and I want to make sure you're getting everything out of it. So so those videos that were watched like literally 32 views. 32. That's probably like 6 people watching it more than once. So, I mean, maybe 11 people watch those. I'm putting a lot of effort into this, or at least I sort of feel like I am. I don't have anything written down. I'm kind of going off the top of my head because I've been doing it so long that I don't usually need notes or anything like that. But I'd like to think that's, we're being useful here. So until next time, miss y'all. Hope all is going well, and stay dry.